Good afternoon or good morning, everyone. Welcome to the Global Interdependence Center's Executive Briefing. I'm Bill Kennedy, your host, and this is the 10th program in our Analyzing Pandemic series. Today, we're going to explore the cure and the disease with our returning guest, Dr. Jeffrey Gold. But first, I'm very pleased to announce today that this event is being sponsored by the David R. Kotok Global Healthcare Series. The Kotok Healthcare Series was launched within the GIC earlier this spring, thanks to a generous gift made by longtime GIC supporter David Kotok, who's the Chief Investment Officer of Cumberland Advisors in Sarasota, Florida. David, on behalf of all of us at the GIC, I want to thank you and send our appreciation for your leadership, your friendship, and this very generous donation. So thank you. As a reminder, this event is being recorded, and the replay and the slides will be available on the GIC website later today. So now I'm thrilled to introduce our distinguished guest, Dr. Jeffrey Gold. Dr. Gold is the 8th Chancellor of the University of Nebraska Medical Center. He's a nationally recognized leader and tireless advocate for transforming higher education, academic medicine, and healthcare delivery. Dr. Gold graduated from Cornell University's College of Engineering and earned his MD from the Weill Cornell College of Medicine. He completed residencies and leadership roles at New York Presbyterian Hospital, Memorial Sloan Kettering Cancer Center, Brigham and Women's Hospital in Boston, and Boston Children's Hospital of the Harvard Medical School. Dr. Gold has been repeatedly recognized as a top 50 healthcare executive and as a top 100 physician executive, and he's received many national awards. I'm very pleased to welcome back to the executive briefing, Dr. Jeffrey Gold. Welcome. So Dr. Gold, you were last with us on March 19th, and it was 3 months ago, but it seems like 3 years ago have passed. Back then, infections were seeing exponential growth, and the US had its first 100 deaths related to the coronavirus. So a lot has changed in the past 11 weeks, so maybe you can give us an update on the state of the disease and the cure from your perspective.
Well, thank you, Bill, for this opportunity to join you again, and again to echo your gratitude to David Kotok for supporting this series. So what I did for today, before we take audience questions, is I put together a number of slides which sort of look at what's happened in the last 3 months. There's a huge amount of things that we've learned, and then, frankly, there's a good deal we have not. So if we can go to the first slide, just to provide, and one more, please, just to provide a little bit of context. The University of Nebraska Medical Center is part of the University of Nebraska system, and among our multiple campuses statewide, our global outreach, etc., exists something called the GCHS, the Global Center for Health Security, which is a center of excellence created by our Board of Regents that is focused on clinical care operations and innovation, building on research development and training widely in the area of all hazard disaster response. And so while there are many colleges and institutes, clinical programs, part of our large hospital system, etc., that are all engaged here, the primary umbrella part of the organization that I'm going to be responding to is the GCHS, or the Global Center for Health Security, which is an interdisciplinary, interprofessional organization that consists of not only healthcare professionals, but engineers and business leaders and many, many others. Next slide, please. Just to give you some context, the GCHS has a large number of federal partners that we have worked with for years. The GCHS, while renamed about 3 years ago, has actually existed for 15 years or more since the first construction of the biocontainment unit, our quarantine and isolation units, our research units, etc. While it might seem natural that we're predominantly partnered with the Department of Health and Human Services, and of course the CDC, ASPR, NDMS, and the FDA, we're also very closely partnered with the Department of Defense and the DHA, the Department of Homeland Security, the Department of State, the Department of Veterans Affairs, I just ran out of space on the slide to put too many logos on to demonstrate all the federal partners as well as the local partners that we have. And so this is a consortium of a number of different grants, contracts, relationships, training programs, et cetera, that have been underway and in place for a very long time. And so it was a natural shift for when the pandemic began to occur for us to become involved. Next slide, please. I just point out to you that that this document that was created and published in JAMA was based upon a workshop that occurred last summer, last July 19th, if I'm not mistaken. And these are direct quotes from the paper by Berwick and Shine that was published in February in the Journal of the American Medical Association. And I just bring to you the conclusions that say both the federal government and the many localities have made substantial progress in preparing for some of the local events. However, at this point, the U.S. healthcare system is wholly unprepared. This was the conclusion of the National Academies of Science, Engineering, and Medicine in collaboration with the Assistant Secretary for Preparedness and Response, again written last fall. Hard to believe how that reality has occurred at this time. Next slide, please. So the GCHS, the Global Center for Health Security, is not just dealing with COVID-19. We are tracking multiple different areas of not just infectious concerns, but also looking very closely at preparation around nuclear and radiologic, environmental, chemical, different types of trauma, etc. Think that what's going on with the 28,000 American soldiers that are deployed in South Korea right now. There's just a very broad set of issues that the Department of Defense and many other federal departments have developed liaison relationships with, and particularly with the GCHS. So next slide, please. Next slide. So let's talk about this virus. I really like this picture. It's an illustration done by the CDC pre-pandemic, interestingly. It makes the virus look very attractive and very friendly, but as we all know, that is definitely not the case. Next slide, please. So, it was back in January that the proclamation on suspension of entry of immigrants and non-immigrants into the U.S. was issued. At that time, this was the, January 28th or 29th, I believe. There were 15 reported cases in the United States, 8 in Canada, and about 70,000 in China. Hard to believe what's changed in that interval. Next slide, please. This is the, when I was with you 3 months ago, this is what the world looked like. 197,496 cases, approximately 8,000 deaths. And if you flip to the next slide, you'll see where we were yesterday. This was, by the way, the United States on that same day, 3/17/2020, 6,300 cases. Next slide, please. And as you said, David, we're now recorded, and this is probably off by a factor of 10, 6 million cases worldwide with 370,000 deaths. And next slide. Just under 1.8 million in the United States with over 100,000 deaths. There are probably very few of us that are on this call that either don't know somebody or know of somebody who is directly connected to one of those hospitalizations and tragically to one of those deaths. Next slide, please. And then just this slide just underscores the importance of the timing. So this is 41 cases. In the red bars, you see the dates of death. In the green bars, you see the dates of onset of symptoms. And in the blue bars, you see the date of reporting of the death. And so this is days across the bottom. And while we have done some to tighten the difference between the red and the blue, there's still a long lag period between reporting of hospitalizations and deaths, symptomatic onset, and disease transmission. And so while we're looking at numbers as of today, we have to always keep this in mind about the lagging indicators. Next, please. Next slide, please. Next slide, please.
I'm sorry, Colleen, can we change to the next slide, or we may have a camera frozen? Just 1 second, Dr. Gold.
Okay.
Yeah, I'm afraid we may have lost our slide access, but
Okay, well, I can certainly keep talking, and can you get rid of that? You think any of it's on our end, or you think it's all centrally?
I believe it may be on the GoToWebinar end. So our apologies for that, but
Yeah,
maybe we
no
can
problem.
touch on a couple of points and then we can go into Q&A.
Yeah, absolutely. So, there are just a couple of key points that I really wanted to make moving forward. One is we've talked a lot about the concept of flattening the curve. And just to make the point that flattening the curve not only prevents the overuse or the inadequate access to hospitalizations, healthcare resources, personnel, ventilators, masks, personal protective equipment, but it also saves lives. And so it's not just about stretching out the length of the impact of the pandemic, but it's literally about saving lives and saving resources, which directly then connects to the economic and social recovery. And on that point, I have a very nice slide that you probably will never get to see that talks about the very delicate balance between the healthcare wellness and the social and economic factors. And while these things may appear to be conflicting, I would say they're actually very, very highly aligned here. And then, if we can get the slides back, I will talk about some of the things that the Global Center for Health Security has done, some of the playbooks that have been developed initially, interestingly, for the meatpacking industry, but an extensive work with the Big Ten, with higher education, with early childhood, etc., just to create some guides for some folks as well, not as a prescription, but actually as a starting point. And so why don't we do this? If we can get the slides back, that would be great. But I think, Bill, maybe the best thing to do is just go to the audience questions, and I'll do my best to talk through them in the absence of graphic support. Would that be okay?
That would be fantastic. And again, apologies for the technical difficulty there. And let me just remind everyone, the slides will be available on the website later today after the call. And if you would like to ask a question of Dr. Gold, on the right-hand panel of the GoTo, there's a dashboard there. You can go on to the gray tab called Questions, type in your questions. That'll put it in the queue, and we'll try to get your question to Dr. Gold. So while we're waiting for those to queue up, Dr. Gold, we did have one comment and one question that I wanted to pose to you, if I may.
Sure, absolutely.
There's a perceived flaw in America in that the data that's being reported is both incomplete and inconsistent. This participant saying that we use statistics on comparison of deaths by cohort, and then we back into the COVID-19 case count and death count really as estimates. And this is partly because of the testing inadequacy that exists. And the question comes down to, what is the true status of COVID-19 infection testing and antibody testing? And how should we sort through there are some states that are reporting testing combined, both the infection and antibody testing get reported as one number. How do we sort through the combined testing reporting confusion?
Yeah, so we could spend the hour on this question, but let's try to make it as succinct as possible, and then I'm more than pleased to take follow-on questions regarding this as well. PCR testing, which is testing that identifies fragments of RNA from the virus itself, by the way, living or non-living virus, is very different from antibody testing. If you combine the unique number of individuals in a city, in a state, that are PCR positive, and the unique number that have antibodies, that will give you the total cumulative impact of the disease. If you ask the question, how many people are infected at any moment in time with COVID-19, then you have to rely on the PCR testing or some of the antigen testing that is going on right now. It looks like we may have some of the slides back, but why don't we just focus on your questions, and we can come back to the slides at a later time. Does that make sense, Bill?
It does. Let me ask one more question, and then I think we'll be able to get back.
Subject for one more minute, if you don't mind. The PCR testing varies somewhat widely from about 85% accurate to about 99% accurate. The antibody testing, because of different types of antibodies, different types of specificity, etc., varies from about 30% specific and accurate to about 97% specific and accurate. And so when we look at the aggregation of these numbers, we have to be very careful that we understand which antibody test we're talking about, how specific they are, whether they're so-called neutralizing antibodies or not. So the questioner brings up a really good point, is are we accurately reporting the data of terms of unique cases? And my guess is we are still underreporting. I don't know how much or how little of that is intentional or systematic, but we're, given the lack of prevalence of antibody testing right now, we're probably underreporting.
And in that reporting process, is it state by state? Is there a federal standard? And what's being discussed in the background about reporting going forward?
So the reporting of PCR positive individuals is standardized across the nation. The test kit, meaning the biochemical assay, the PCR assay, varies not only from state to state, but varies to a great deal even within a state. So for instance, within the state of Nebraska, there are multiple different technologies that are being used that have some small degree of variability and specificity. As far as antibodies or so-called serologic testing is concerned, that is a very different animal. And to the best of my knowledge, there is, other than the EUA's certification, the emergency use authorizations, there is really no other standard for that right now. And how the individual states or municipalities are reporting that is unknown. And I believe it is and will be a state of a bit of confusion for a while. Now, we have worked very closely with the Department of Health and Human Services of the state of Nebraska to try to get this ironed out so that we're only reporting unique cases. Same thing's true about our mortality statistics. We're double checking to be sure that when we confirm that somebody is a COVID-related death, not only that they've actually died, which of course is pretty obvious, but that there is a true connection either to serologic testing or to PCR testing.
Great, thank you for that. So Dr. Gold, and to the audience, apologies for the technical difficulties. I think electricity is back on. So Dr. Gold, if you want to point to a slide, we'll see if we can't go to that slide and we can resume.
Yeah, so let's go back a few, if that's possible. And one more, yeah. So I think you're going forward and not. Can you go backwards? Keep going backwards. Keep going backwards. Keep going backwards. Or are we frozen again? Yeah, let's stay here. This is a good starting point. Oh, this is a delicate balance. Let's go forward one or two more. You've seen these maps. One more. Next, we've talked about flattening the curve and reducing deaths and hospitalizations. Next slide, even more complex. Next slide. So let's stop here for a minute.
Sorry, Colleen, we need to go back one slide to the balancing picture.
There you go. Let's stop here,
Great.
please. So we would say that the key mitigation and response actions are indeed a very delicate public health and social economic balance. And the data, we've just been talking about the testing. needs to look at real time. It's got to be look at the progression or the regression of the disease. It's got to look at capacity of our healthcare system, supplies and equipment and personnel and workforce. It's got to be regionally determined. And then it's got to be staged over a 14-day period. You know, people ask all the time about all of the predictions going into this pandemic were hundreds or up to 100 million infected Americans. Now, that was all based on an R naught that was so-called without any response. So given all of the non-pharmacologic interventions that have occurred, we've been able to markedly flatten this curve. And that's why we're seeing a much lower impact on it. And then finally, to say that these need to be scientifically based decisions based on testing, and more testing. And your question has already identified that, of all different types. So next slide, please. So this is a dashboard that we use here in the state. It looks at, in the far left column, daily confirmed cases, percent positive cases on a given day, and confirmed deaths on a given day against statewide benchmarks. It looks at the number of occupied hospital beds by COVID patients, ICU beds, and ventilators. And then it creates a number of trends of both velocity of change and acceleration of change. So you should think about the velocity of change like the R naught. So this is the change over one disease cycle. And the acceleration of change is how fast the velocity is changing. So you see, if you were to look at the state of Nebraska, and this was shot yesterday, this is updated every 24 hours, it gives us an idea of what the state is doing, all 2 million people in the state, relatively small, rural, sparsely populated communities, and fairly large urban centers. Next slide, please. Can we go to the next slide, please? And this just shows you some of the run charts of what the data looks like. This is hospitalization and ventilator use. One more slide, please. Yeah, so this breaks the state, which is divided into 6 healthcare collaboratives, HCCs, and you see, and they're sort of geographically located. That is to say, the one in the upper right is the northeastern corner of the state. The one in the lower left is the southwestern corner of the state. These 6 districts, and this is the same dashboard, the same metrics, looked at on the same day and the same time, all updated every 24 hours. And I just show you this to make the point that regionality makes a lot of difference. If you look at the Upper West, which is the panhandle part of the state, granted, maybe being in mountain time makes a difference. You know, they look a lot more green than the northeastern part of the state, or even the southwestern part of the state. And so, indeed, even at a more granular level, the state is broken into 20 local public health districts. And even if you look at those 20 local districts, you see quite a bit of difference from one part of the state to the next. And this is a tool that we've developed that has been provided to multiple states across the country. Indeed, this is a product of the Global Center for Health Security. Next, please. So, you know, I get asked a lot about what are the key professional and pharmacologic interventions that are necessary to move forward. And, you know, this audience, I'm sure, is aware of most of these, to develop and confirm and validate new tests, to make sure the antibody tests are deployed and validated, contact tracing, syndromic surveillance, monitoring for secondary and tertiary rebounds. But more sophisticated than that is antiviral development, vaccine development, and then specific mitigation and response guides, and wherever necessary to advise those elected and appointed officials who are making community-specific recommendations, the so-called designated health measures. Next slide, please. This is just an example of several of the playbooks that we've built. The first one is actually on top, had to do with you know, a guide for the meatpacking industry. There's an interim draft that's about to come out probably later today for the Big Ten. We're working very closely with many other large athletic organizations, different sectors of industry. We have one that's out on higher education, another one on early childhood, another one for small and large businesses. And again, these are about 25 or 30 pages of just guiding ideas and this is in direct response to a huge outcry for, where do we begin? Think K-12. What do they need to know in order to reopen schools in this coming fall season? Next, please. A number of important publications and research, a good deal of work that we've done and that others are doing across the country in the transmission potential of this virus, learning about surface and aerosolized and droplet spread infection, and then participation and leadership in national trials. As you may know, we recently published as a collaborative the first of the remdesivir programs, and the phase 2 remdesivir trial is already started. And I'm proud to tell you that our institution was the first in the country to enroll patients, and we've already enrolled about 25 patients in the phase 2 remdesivir trial. But again, evidence-based approaches to transmission, treatment, prevention. Next, please. We may have talked early on about the development of mobile applications, but we've now developed a platform for self-screening and surveillance, which has been quite widely used. There are over 100,000 users now on the Apple platform. I don't know how many use the Android platform. And again, this is a self-surveillance tool that was again developed by the Global Center for Health Security and has been widely in collaboration, by the way, with the leadership of Apple to be sure that these are all highly vetted algorithms, regionally specific, not prescribing healthcare, but just simply making recommendations. Next slide, please. I think we're getting to the end of my slides. We've had the opportunity to advise our federal delegation and others in leadership roles in the United States Congress and in the West Wing, and there are very specific sections that have been developed about not only what needs to happen today, but about what the future preparedness needs to look like, scalability of access, testing, personal protective equipment, just thinking through what the next 6 months and the next 5 years might look like if we needed resources to deal with that. And then there are parts of all of these bills, including some work we're currently doing with Congress and the West Wing to specifically look at what the next bill will contain. Next, please. These are the key NPIs, or community mitigation actions. I always repeat them. I think they're very important. They do not get updated much, but even as we move through this pandemic, these are going to be around for a good deal of time in the future, and so we need to boldly place them widely in our places of work, in our schools, in our churches, and other places where we can use these to protect our community and try to make sure that we limit any resurgence of the viral pandemic. Next, please. So I guess in summary, I would say that there's an option here for many organizations to continue to play leadership roles in public health and safety and federal defense, to expand the health security professional education, to continually meet the need for scalable, all-hazard 21st century threats, and then to grow the federal investment in research, education, and clinical care, to bolster our new national opportunities for public-private partnerships all around saving lives, growing economic prosperity into the future. And then I think maybe one more slide, if you don't mind. Next slide. So this is the final paragraph, the final sentence that was in the Berwick and Shine article that I referenced early on. If you could go back one, please. And that is that progress will require unprecedented participation and contribution from an enormous range of stakeholders, including government and nonprofit and private sectors and professionals involved in all facets of healthcare. Again, these are not my words, but this is Don Berwick and Ken Shine from the JAMA publication that I referenced early on in my comments. Could never be more true. So with that, Bill, why don't we go back to your questions, and I look forward to trying to answer them in our few minutes remaining.
That's great. Thank you very much for the presentation, Dr. Gold. Apologies for the problems with the slides, but I think we get the gist and an opportunity to review those slides on the GIC website. Again, if you'd like to ask a question from the dashboard, please go to the question tab. You can enter your question. Let me go through a list of questions that have come up. So given that protests are outdoors and many of the participants are wearing masks at these protests, what do you think will be the effect on the measured infection rate over the next 3 weeks?
Yeah, great question, Bill. The answer to the question is nobody knows just yet, but you're asking my opinion, so I'm freely going to share it. You know, as I have watched the videos from across the United States and frankly in our community as well, I see individuals of all ages, of all colors, of all different racial and ethnic groups. And I see individuals wearing masks, and I see individuals not wearing masks. I see individuals trying to maintain 6-foot social distancing, and I see individuals tightly packed into very, very small areas. There is very little question that the lack of use of personal protective equipment and the lack of social distancing is going to have an impact. And indeed, it may have an impact disproportionately in certain aspects of our racial and ethnic and gender and aged population. I think this weekend is going to be a critical moment in time. And I say that for 2 reasons. One is it's approximately 7 to 10 days from when these large social distancing protests started to begin. And it's also going to be a question of whether there's going to be continued broad scale countrywide activity in these areas, or whether it's going to slowly start to be reduced. I will tell you that we here in Nebraska are quite concerned. You know, hope is not a plan, as we like to say. So we are plan for the worst, hope for the best. So we are deploying a considerable amount of increased testing, access to personal protective equipment, extra hours at many of our clinics, and other such things broadly across the state, but particularly in the urban areas where these gatherings have been most intense.
Great, thank you for that. There's a question here regarding modeling. Back in mid-March, the hazard models were generating projected outcomes closer to about 2 million projected deaths compared to the realized outcome where we are around 105,000. The question is, where are the early models, where were they wrong? And what have we learned about the design and the parameters of those hazard models?
So just to be very clear, I certainly understand the concern about the question, but I don't understand in full openness the methodology that's used in building all of those different models. And there were several different models there were even CDC models that were brought out. If you remember, there were 4 different models that were predicted. But they're all based on what's called the R0, which is a so-called reproduction factor. And what that means is if a single individual becomes infected, how many other individuals are they likely to infect in the course of their illness? So for measles, that number is between 9 and 10. It is a highly, highly infectious agent. Nobody knew the infectious capabilities of COVID-19, of the SARS-CoV-2 virus. It was estimated at that time to be approximately 2, meaning 1 individual would infect 2, 2 would then infect 4, etc. The R0, however, is calculated in the absence of mitigation. That is to say, in the absence of non-pharmacologic interventions, no mask wearing, no social distancing, none of the shutdowns, so to speak, that have occurred widely across our country in restaurants and churches and schools and universities, etc. So all of those mitigation factors serve to lower the reproduction factor of the virus, which then change all of the modeling. And that's why the modeling is so imperfect, because it all depends on how much or how little a given community is successful in reducing the reproduction factor. So we've seen in every state and in almost every municipality are these so-called super spreaders, or what I like to call mini cruise lines. So these are long-term care facilities. These are senior citizen facilities. These are early childhood facilities. These are meatpacking plants where close quarters produces an explosion or mini epidemic, if you will, within a community, which then spreads to the rest of the community. And then it's almost like whack-a-mole in a sense, that you put in all intense personal protective equipment, training, testing, etc., and you control the spread in that one location. And then just like a tinderbox in another one of these microcosms, a mini epidemic occurs and it increases spread back to the community, because all of these workers and individuals take the virus home. You've gone through an intense period of NPIs and then control it and just sort of wait for the next one to occur. So as we've continually reduced some of the NPIs, reopened restaurants, spas, starting to reopen some limited athletic events, churches and synagogues and others across the country, we are starting to see some resurgence. Indeed, of the states that reopened, there are concerning trends, at least 15 to 18 of them right now, and it's probably too early to really know what the long-term impact of that is going to be, and whether testing and syndromic surveillance and contact tracing will allow us to continue to control this, or whether it'll once more get out of hand. And that's all in advance of what's going to happen in mid and late August, when schools, the K-12 system, colleges and universities and others start to bring our faculty, students, and staff back to the campuses. You think about what a mini steamship is going to look like. The University of Nebraska system writ large, it's about 55,000 students. That's more than a mini steamship. Add to that the faculty and staff. So we're looking at a very, very robust, what we call de-densifying strategy, to try to maintain these distances, use of masks, extensive availability of testing and other such things, contact tracing, in order to safely do that. I will tell you that we've surveyed our students, and categorically, this is not from their parents, this is from the students. They have the single highest priority that they have, and I think they're right on, is their safety. The safety of themselves, the safety of their parents, their grandparents, their families, etc. So any decision we make, and I think this is widely spread across the country, whether it's the NCAA, Major League Baseball, or higher education, is built around the safety of the community we serve.
Great, thank you for that response. Back in March, I think you made the comment that you thought the virus spread, and therefore the virus, the policy response to the virus spreading was going to be regional or rolling. In fact, your slides just show that you actually have different categories in different parts of the state of Nebraska. And it seems like the federal government has passed on the decision-making process to the state and local level. Has this been a strength or a weakness in terms of the policy response, do you think?
Well, I think it's a combination of both. There's little question in my mind that local communities need to have flexibility as to how tight or how loose the non-pharmacologic interventions are. For instance, we have a very, from our directed health measures, we still have several counties in the state of Nebraska that do not allow access to restaurants and churches and other types of social events. We have others that do, and it's based upon the PRAM model, the multicolored dashboard that was in one of my slides. However, on the federal side of the equation, what we really need and have over time acquired is access to supplies and equipment, access to testing, frankly, access to clear-cut definitions is, what is a COVID-related death? That may seem like a really obvious question with a really obvious answer. We learned many years ago that, one is not only merely dead, but really quite sincerely dead, going back to the days of the Wizard of Oz. But for instance, if somebody dies in a hospital on a ventilator who is COVID positive, I don't think we'd have a lot of question in confirming that. But if somebody is 10 days after being, quarantined at home, looking well, feeling swell, but still virus positive, and goes out to get the mail and keels over from a heart attack, or ends up being run over by the local bus driver, or who knows what else, is that a COVID-related death? And so having absolutely clear definitions of these factors is important, and that will help us on the federal level. You asked me earlier about how are we accounting for antibody positivity as opposed to antigen and PCR positivity. It would be very helpful to have a single system in place that allowed for clear reporting on this. We'll get there. I mean, I guarantee you we'll get there, but it would be nice to have it real time. I think the CDC has really ramped up the number of guides that they've put out. For instance, our higher education guide is a collaborative relationship. The meatpacking guide is a collaborative relationship where, we work with them, they work with us, and many other large universities across the country to try to bring together some of the best thoughts on these subjects. So both a blessing and a curse, I guess I would say.
Thank you for that. So this question is near and dear to the Global Interdependence Center. We're spending a lot of time discussing and researching interdependencies, both positive interdependencies and negative interdependencies across all types of policies. What do you see as the greatest positive interdependency in the healthcare system that's become evident from this pandemic? And what do you think the greatest negative interdependency might be?
Well, the positive interdependencies, which frankly I think far outweigh the negative ones, but the positive interdependencies, in my mind, are bringing together the best and the brightest minds to deal with this. And the research work, the vaccine development work, the antiviral development work, the transmission aspects of this are a global effort. And, if you think back to the Ebola outbreak in Western Africa in 2014, the reason that never became the pandemic of what we're talking about now is because of the interrelationships and interdependency that focused laser-like resources into those communities in order to keep the virus from spreading in a high impact way. Now, it did get out of Western Africa, and by the way, for those of you that are not tracking, there have recently been 5 reported Ebola deaths from a new strain of Ebola Zaire in Western Africa. That is of great concern to us here in the Global Center, because to have to deal with that at the same time we're dealing with coronavirus and everything else that we're dealing with right now would be yet one more cruel twist of fate. And by the way, we should also be well aware of, as bad as the coronavirus pandemic is, if this was Ebola with a 75% mortality rate, we'd be dealing with a much, much different situation. But anyhow, it was the global interdependence and the connectivity that helped to bring together effective treatments, vaccines, and containment, mostly through NPIs, non-pharmacologic interventions there. The downside of it is really relates to supply chain, and that is that as the pandemic has rolled out across the country and across the world, we've seen dramatic shortages in supply chain because of the unprecedented and rapid spread of this disease. I mean, even if the R0 is 2.0 and not 10 like measles, if you just do the math on a 10 to 14 day cycle, if we were not able to affect the non-pharmacologic interventions, there'd probably be 100 million infected Americans by this point. I feel that, and indeed, you look at the numbers we have now, when all is said and done and we develop stable antibody testing, we're probably going to realize we're off by a factor of 10 in the total case prevalence in the United States. And so, I think there are lessons learned to enhance our interdependence and also to create enough resilience in some of our supply chains that we can do it. And then, of course, when supply chains get tough and there's a lot of pain and suffering in any community, that sharpens the political acumen in many different ways. And then things that are, what should be scientific and driven by best practices become overtly politicized, and that just stresses the ability to be and sustain effective interdependence. And so it's not a surprise that these sort of things not only bring out the best. I've seen so much teamwork. I've seen heroism of levels that that you would never believe in dealing with some very sick patients and families, in dealing with some of the long-term care facilities, in dealing with the extremely racially and ethnically diverse communities that we serve. And yet I've seen just the opposite of that as well. And I think we need to understand that pandemics and these types of highly stressful situations bring out both the best and the worst, and they stress our interdependence.
Great, thank you. This member is asking a question about the second wave, and you've touched on this a bit, but what's the outlook for the timing of a second wave of infections, and what are the implications for the next wave on the national healthcare delivery system? And maybe, what have we learned, and will the flattening of the curve be the same, or will we think of it differently in a second wave?
Well, I think the recent advisory by the World Health Organization sort of says it best. And what I mean by that is they said, while it's really great to prepare for the second wave and possibly the third wave, we are nowhere near through the first wave. And I don't know whether we're in the fifth inning, to use a sports metaphor, or the eighth inning or the second inning. We have a ways to go here. And there's little question in my mind that we're not going to, even if there are going to be multiple peaks and multiple valleys, those valleys are not going to be at zero for a very long time. And so we sort of have to get used to living with the virus on a day-by-day basis until we have access to effective vaccines. And unclear, A, what access means, scalability, and secondly, unclear what effective means, meaning will it reduce the prevalence? Will it reduce the severity, or both? How long will it last, etc. So, every pandemic, every epidemic that we've seen, large and small, has had second and tertiary waves of prevalence that had to be dealt with. We'll be dealing with it with more knowledge about transmission. We'll be dealing with it with better antiviral tools, think remdesivir and a whole host of other antivirals, polyclonal and monoclonal antibody therapies. I mean, there's just a whole host of things that are being developed so that by late summer, early fall, we'll have many more arrows in our quiver to deal with this, and hopefully can continue to knock down mortality. Interestingly, if you look at mortalities across the United States, in the first month, the hospitalized mortality rate was 4 times to 5 times higher than in the second month that we've been dealing with this. And in the third month, it's far lower than that even. So we're either admitting less sick patients to our hospital, or we're doing a better job of caring for them and getting better survival statistics, or both. And I think that's a combination of both. So a good deal of optimism from my perspective that we'll have better tools, more arrows in our quiver, but a realization that we're going to have to deal with this for a long time to come, because even with the development of an effective vaccine, it's going to take a long time to get to herd immunity.
Thank you. So you touched on this a little bit, but it's a question focusing on the cure. What have we learned about the biochemistry of the COVID-19 virus that needs to be addressed through vaccination? And when do you think an effective vaccine can be developed and deployed?
Well, we've learned a lot about the virus and its genetic shifts over a period of time. From an antiviral perspective, there have been a number of different approaches that have been tested and are currently under development. Everything from drugs like remdesivir that gum up the genetic replication mechanisms to drugs that blunt the extreme inflammatory response, to drugs that blunt the ability of the virus to bind to human cells. And the idea being is that if you come at this with multiple different modalities, you have a higher chance of being effective. And that's what the clinical trials are currently looking at. You know, I'm really very pleased about the remdesivir trial. While it's by no means curative, it was a multi-center trial of about 65, 68 different sites across the world. You talk about interdependence. It took multiple countries, 37 countries, by the way, participated in the trial, and it demonstrated some efficacy, not cure, but some efficacy, which then opens the door to supplemental and multi-pharmaceutical trials. But coming back to your question about vaccines, there are well over 100 vaccine platforms that are under development worldwide. There are, I think, 28 or 29 in the United States that are at fairly advanced stage, that are a good number now that are currently in what we call phase 1 clinical trials. Phase 1 clinical trials are safety trials. Phase 2 would be efficacy trials. And to get into a safety trial, there has to be both proven safety and efficacy in the laboratory. And so, I would say that we're months away from some preliminary information on even the earliest efficacy trials, maybe the end of this month, the beginning or the end of next month, at least on a preliminary basis. And then we're going to have to get into broader efficacy, meaning what about children? What about high-risk populations? What are the racial, ethnic, and gender specifics about a vaccine? And once all that is understood, we're going to need to get into the manufacturing, because to establish herd immunity, we're currently thinking we're going to have it in roughly between 60 and 70% of the population. So that's well north of 200 million people. And there's going to be an awful lot to manufacture that kind of scalability of dose and then get vaccine to those individuals. So we've been advising and working very closely with our local health departments and actually starting to develop policy and procedure around how we're going to reach out to which populations at which time first, et cetera. And there's a lot of debate on this, whether you should start off with the most vulnerable populations or whether you should start off with the vectors, which are, school-age children, basically, who are always carrying something home, and you'd really like them to not carry COVID-19 if you can possibly avoid it. So all of that is, very much a work in progress. But I will say this, that there has not been that much genetic shift of the virus that would make the vaccines ineffective. Now, that is extremely different from the experience we had with Ebola, because as we started to develop, I'm talking worldwide back in 2014, vaccine panels for Ebola, we saw significant genetic shifts of Ebola Zaire, which was the infectious agent in Western Africa, to the point that some of the early vaccines that were developed would have been significantly less effective than the vaccine that we have now. As I said, there's been a very early but concerning outbreak. A lot of work is going to have to be done in the very, very near future to see whether the vaccines that we currently have, which were 95% effective in the DRC, whether or not they will be effective in this current micro outbreak in Western Africa. A lot needs to be done in there. And then the enduring question here is whether this is going to be an annual event and we're going to have to get revaccinated every year, whether the vaccines, and that'll have to do with whether the immunity is sustained or not. And then we'll have to answer the question of whether the vaccines prevent the disease or whether the vaccines just make the disease milder and reduce hospitalization and mortality. So a lot of questions to answer, but well along the way, I would say.
Thank you. So we have time just for two more questions. This member is asking a question about whether or not your center does research on the topic of the relationship between biodiversity, degraded habitats, novel ecosystems, and how that ties into pathogens.
So I am sure we do, but I'm certainly not the subject content expert in that area. The Global Center is just that. It is global, and we are doing an extensive amount of work in Africa, in the Far East, in the Mideast, less so in South America, some in Central America, not specifically focused on COVID right now, but in many different areas, including malaria, Zika. I mean, you name it. I showed you the map of the world with all of those scary names. Each of those is a research project going on here.
Okay, thank you. Our last question, if the healthcare system can handle the COVID-19 caseload, are there any objective critical levels that government should use to limit economic activity?
Well, from a very philosophical approach, I see tight alignment between the prevalence of the disease and the economic recovery and the social recovery that we're all focused on. Believe me, I am incredibly well aware of the impact of poverty, food insecurity, the impact of domestic violence, child abuse, crime levels, suicide, depression, etc., that is present today as a result of this pandemic, let alone the impact of sustaining it over a period of time. And all of that goes into this very delicate balance that I try to graphically predict and project in the slides. However, when we say opening up and restoring the economy, we have to be able to get people to feel safe and secure. College-age young women and young men are not going to come back to college if they don't feel that they're going to be safe and secure. I can't imagine that we're going to see too many people at Division 1A athletic events if they don't feel safe and secure that there's some control of the spread of the virus and some way of treating them successfully if they should become ill. Granted, there are no good metaphors for this, but a lot of older individuals, people with multiple medical vulnerabilities and comorbidities, don't go to large events in the peak of the flu season for exactly that reason. So I personally believe that to reestablish the very best of our economic viability is to establish the health and wellness of our nation and the world.
Great, thank you very much. So Dr. Gold, we're going to have to leave it there. We thank you for a fascinating discussion and spending time with our GIC community. So thank you very much. Audience, before we close, three quick things. First, a programming note. Next Thursday, a week from today, on June 11th, the program is going to be the challenges in economic forecasting. And this will be with Philip Carlson Slezak of the Boston Consulting Group, Megan Green, a fellow at the Harvard Kennedy School, and our friend Don Rissmiller, who's the co-founder and chief economist at Strategas Research Partners. That will be followed on June 18th with a fireside chat with Loretta Mester, the president and CEO of the Federal Reserve Bank of Cleveland. Watch your inbox for invitations to these events. Second, we welcome all of our new members who took advantage of the GIC membership discount over the last few weeks. We welcome you. We also wish to thank those of you who recently renewed your annual memberships. Finally, a feature of the David R. Kotok Global Healthcare Series is that Mr. Kotok has established a very generous matching donation challenge. So through July, any donation made will be matched dollar for dollar up to a total of $50,000. So in other words, a donation of $100 becomes $200 in value and impact through this matching gift. All of the donations will go directly towards bringing the GIC's high quality content to the general public for the remainder of this year as a public service. So to learn more about membership or to take advantage of the COTAC series donation match, please go to the GIC website at www.interdependence.org. As we conclude, I encourage you to take 60 seconds to respond to the audience survey. Your feedback's important to us. Let us know how we can improve our programming. Thank you for your attention and good afternoon.